All right, we can go ahead and get started. So hello, everyone. Thanks for joining Spotlight on Data Quality, Getting to the Root of the Problem. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded, and we'll provide it to you for after future viewing. Throughout the session, you'll all be in listen-only mode, but if you have any questions, feel free to type them into your GoToWebinar console. At the end of the presentation, we'll have a Q&A session. We'll get through as many questions as we can, but for any reason yours is not addressed, we'll follow up with you right after the webinar. Today we have two speakers, IMO Senior Sales Engineers, Andre Namierad and Megan Broom. As mentioned before, if you have any questions or comments while our presenters are speaking, type them in to the questions panel. With all this being said, I'll pass it over to Andre.
Thanks, Jordan. So team, we're going to be talking today about Spotlight and data quality, especially around clinical data as it flows through healthcare ecosystems and getting to the root of the problem. So for those of you that are on the line here today, you're probably knowing the market situation that's here. As healthcare data flows from one organization to another or from one software vendor to another, key data points are lost. Happens all the time. And as organizations take efforts to help crosswalk these data sets, they become less specific over time in an effort to decrease risk and to fill in those gaps. Organizations do this all the time. They a lot of times can't take into consideration the context of what is going on with the clinical vernacular or might not have the experience to do so. So to alleviate risk will go less specific in many of these use cases. And as those crosswalks are added to records or added to data points, the codes that represent these crosswalks are updated all the time. So the many-to-one, one-to-many, many-to-many correlation, as it's updated and managed and maintained over time, becomes a maintenance burden on organizations to take on. And as organizations want to use this data to derive analytical insights or on-demand analytics, they build models that try to address care with this data, but are noticing that it's lost its trust over time. And if this resonates with anybody on the line here, you definitely come to the right place. So IMO HIMSS 2020 had sent out a questionnaire to say, well, as you think about data within your ecosystem, and for the healthcare organizations that are on the line today, how are you guys using this data? And you had answered, I'm using it for quality measurements, documentation improvement, cost of care management, revenue cycle enhancement, decision support, treatments, protocols, a whole host of other different use cases. And these are direct care and quality insights operations. However, as you look at what you think is the underlying problem of data quality, again, this is your answers, not IMO's. The interoperability and untrustworthiness of data was a key indicator in this whole section. Now, I'm going to come back to this top part up here about data inconsistency due to subjective documentation in later parts of today's presentation. But we'll focus on as data is flowing through the ecosystem or as organizations are trying to manage that data, it becomes less viable, less succinct over time. And again, this is not IMO answering these questions. These are the organizations that we pose these questions to answering them themselves. So if you're trying to address the problem, how are you trying to address it and what impact do you think might have into that workflow? And in 2021 and 2022, the big focus of organizations has been on physician burnout. But to address this problem, you have to lean on the subject matter experts, the clinicians in the world, to manage and maintain that kind of data because they are the experts, which as again, they are leading, they are focused on documentation and documentation improvement initiatives in the first place. So you're putting additional effort and workload on their shoulders, which will lead to physician burnout. And if any of them don't have time or might not have the accuracy or relevancy, or there's team members that might not have the accuracy or relevancy or experience behind the scenes to manage and maintain this information, it wholeheartedly will lead to operational inefficiencies. And if those operational efficiencies aren't done correctly and they're not kept up to date, they wholeheartedly can lead to patient safety. And again, these are not IMO's answers. These are the organizations that we asked out into the ecosystem these kinds of answers. This all leads to the exact same thing, that bad data will equate to downstream impacts. So as we go back to this point up here, data inconsistency due to subjective provider documentation. If the assumption is that the provider is documenting incorrectly or non-comprehensively, that can definitely lead to downstream impact. But we'll talk about why that's an important point to keep on here in this next section, which let's focus on the clinician. We spend billions of dollars as an organization to help in the documentation or workflow of clinicians in the point of care. And we built these large ecosystems of data repositories and data workflows to help enable this type of clinical end user to document more appropriately and more effectively over time. But as more and more software solutions came into the ecosystem, the clinician has more and more data points to understand and interject in. And this can lead to the telephone game in healthcare. So let's maybe focus on some of that telephone game here specifically. To any radiation or medical oncologist, breast cancer metastasized to pelvis could be documented on a problem list or on a visit diagnosis. And for those of you that live in the coding language and in the coding world, to represent this kind of complex clinical condition, you need to represent that with 4 SNOMED codes and 2 ICD-10 codes today. That can change tomorrow. But let's assume in many cases, software services that are catering to that provider doc might only be sending the minimum acceptance criteria of a transmission. Again, getting to that interoperability problem statement that everyone here on the line had identified as a key indicator of a problem. And if the primary representation of that data is just a SNOMED code, organizations will need to crosswalk that SNOMED code to an ICD-10 code for billing purposes, for risk insight purposes, for a whole host of other different use cases that are out there. But if all you're receiving is just the SNOMED code and not taking consideration the context of the clinician's documentation, that SNOMED code and crosswalk to an ICD-10 code is just breast cancer. It's a very unspecified breast cancer at that. It definitely does not mean breast cancer metastasized to pelvis. But let's assume you might not have ICD-10 at all, but you might have a comprehensive representation of SNOMED, but you're not taking into consideration the context of breast cancer metastasized to pelvis. You might, again, go down the line to look at these SNOMED codes and furthermore crosswalk them too. And again, not getting the specificity that you might need. The closest that you might get to, in this case, might be metastases of malignant tumor of the breast SNOMED code to an ICD-10 code grouping. And you might get close to the RAF score pivot, but it is not the exact representation of a specified metastases ICD-10 code. The only way to get to that is if you take the context of the description. And if you go to the last SNOMED code crosswalk, you're definitely not getting that risk insight either as well. So as we take a look at this exact experience here of crosswalking code set to code set, this is the problem that happens with many-to-one, one-to-many, many-to-many correlation. You're not getting the clinical context of the patient, which leads to that downstream data impact and the ability to have untrustworthy data if you're not looking at the description itself. So let's take a step back and say, all right, well, let's focus on the modeling. How can we help grab patient populations or understand patient populations and tune our models more effectively, even in lieu of patient populations maybe not even being coded correctly? And this is a problem that happens in the industry. It happens quite often. So if the doctor here is diagnosing a problem with malignant neoplasm of the breast stage 3, that's a complex problem. But as we've identified in the last slide, if I'm trying to grab the billing code, the ICD-10 code, that's just breast cancer. If I know that it's a breast cancer code, I could probably group it within a cancer cohort. But if I'm trying to track a cancer survivorship plan that identifies show me all stage 2 and stage 3 patients and not stage 1 or stage 4, the AI algorithm will look at the code sets themselves to try to find that. But as we've identified, those do not identify staging appropriately. And you're also kind of crossing your fingers that the comprehensive representation of that coded data behind the scenes actually can help the AI tune the algorithm to meet it. And this is the problem that happens in industries. Without focusing on the underlying data quality, you will fail on all AI ML algorithms that represents 20% of your population and 80% of the cost of care. So which rule is correct? If you have a patient population that has breast cancer stage 3 on a problem list, like a single patient, and you have another patient over here that's chronic kidney disease stage 3 on their patient problem list as well too, and you're saying, show me all patients that might have a stage 3 cancer, because you might want to do this for research, you might want to do this for quality insights, you might want to do this for AJCC cancer survivorship plans, a whole host of different reasons, but we're going to use this as an example. To take the two SNOMED codes that are part of this, and again, required to be captured, but in many cases, only a primary SNOMED code might come along for the ride. But let's assume even both codes do come along for the ride. Breast cancer shares the same stage 3 SNOMED code as chronic kidney disease. So if you're tuning the algorithm to focus on stage 3 code to try to find your patient populations, you will get a larger inclusion criteria onto the patient population than you would if you were to focus on the clinical expression itself. And this is the problem with healthcare. If you're not helping, or if you're not accurately identifying and complementing the clinician at the point of care and bringing their data into data ecosystems appropriately and comprehensively, data quality will always be an issue. But the underlying problem is not the clinician. It's actually how the data is flowing downstream with the telephone game. And again, that's not me answering that question. That's you guys answering the question here. And don't take my word on it. Amy actually recently released a study out there that said, all right, well, if I wanted to crosswalk patient populations from an ICD-10 code or SNOMED or ICD-10 code to a SNOMED code, that SNOMED code crosswalk was 75% different than what the clinician's expression was at the beginning of the statement. That is a big problem. And that's the problem when you focus on crosswalks to fill in those gaps of the telephone game. Crosswalks will break, and they'll break all the time. Now, had the organization used the original IMO code, and if those of you on the line here that are not familiar with IMO, my colleague Meg Broom will get into that in a moment, but had they used the same IMO code that came along for the ride, that was 68 to 66% more specific than the crosswalk from ICD to SNOMED. That's a key differentiator. And even though IMO is not maintaining the data warehouse, it begs the problem, if we were, could you have gained better insights into the data quality of your patient population? And this is the problem that happens with crosswalks. And to give you guys graphical representations of this, this is a key indicator, right? If I'm dealing with ICD-10 codes, I have about 70,000 ICD-10 codes. And in the diagnosis and symptoms domain of SNOMED, I have about 120,000 codes. But there will be gaps. And this is the problem that happens with code-to-code crosswalks. You'll always get that many-to-one, one-to-many, many-to-many correlation that happens behind the scenes. But IMO as a company, we created interface terminology that has well over 410,000 concepts that are not beholden to the standards themselves, which allow us to get to levels of specificity that are more specific than the standards themselves. Again, helping bridge the gap between that clinician's expression at the point of care and appropriately coding and comprehensively coding that data as it flows downstream. And not only maintaining that data, so that as organizations want to do that stage 3 chronic kidney disease query or a stage 3 breast cancer query, you can identify the correct grouper at the level of specificity that you want and do that at a terminology level. Again, bridging the gap between that clinician's expression and those code sets that always change or will change quite often at the time. So as we think about what IMO can do for you all, these are the questions and comments that you had identified as the big problems in the industry. And this is where IMO can help. So who is IMO and why do I care as an organization? IMO is literally the best kept secret in healthcare. And I'll pass the baton on to my colleague, Meg Broom here to talk about what IMO does.
Thanks, Andre. My name is Megan Broom, and I'm a senior sales engineer, one of Andre's colleagues here. And picking up where he has left off, who is IMO and why should you care? IMO is a healthcare data enablement company, and you may recognize us from our point of care workflow solutions that allow for search and capture with the clinical documentation process. And while IMO does that and does that very well with the majority of EHR partners in the United States, over 89% of providers use our content every day. IMO also powers the solution to complex approaches to enterprise-wide level data quality issues, which is going to make your patient information actionable across the healthcare ecosystem. And why is IMO the best person to do this? Looking into the next slide, you can see that IMO allows for clinical expressivity. We are not constrained by a single code system, and this has been proven to be the best way to preserve clinical intent. Why do you care about preserving clinical intent? It allows the provider to treat the patient better today and for the next provider to treat the patient better tomorrow. But clinical intent is difficult to preserve because there's so many different ways to say the same thing. A great example here is heart attack with ST elevation. There's different word orders, different naming conventions, all to describe the same condition. And IMO allows providers to search the way that they were taught, document the way that they are most comfortable, but the administrative code mappings are standard on the back end and come along for the ride to be maintained by IMO. After you choose the IMO code mapping one time, you're future-proofing it for any code updates that may happen in the future. This is IMO's core competency. Building off of this core competency on the next slide, you can see that IMO has a unique ability to solve for the clinical data quality problem across the healthcare ecosystem. There are so many ways that data can go wrong. Starting at the left side of this graphic, you can see the capturing at the point of care can happen within different systems. It can sometimes use IMO and sometimes not. And when you go to aggregate all of these various systems where clinical data is being captured, then what most healthcare systems are doing today is moving on to the analytics portion and trying to make informed decisions based off of what their self-service analytics platforms show them. But it's the age-old problem of dirty data in and dirty data out. And without this critical step in the middle where IMO sits, the normalization and enhancement of that data set, now you're able to put clean data into the analytics platforms and truly make informed decisions to improve EHR workflows, patient outcomes, clinical quality measure reporting, all the way down to clinical research to affect patient outcomes in the future. But you can't do this without a unified data set that is mapped and maintained to all the latest and greatest standard codes. Moving on to the next slide, Andre. This is a real-life example of how IMO is able to do that validation and enrichment prior to analytics. So think of something like rectal cancer metastasized to bone. This came through from a real client with just a singular ICD-10 code. And what we found is that while their ICD-10 code was correct and we were able to validate that, they were missing another ICD-10 data set, which you can see below. The neoplasm metastatic data set was able to be enriched onto this term, as well as the ICD-9, ICD-10, and SNOMED codes associated with this concept. So IMO has a unique ability to recognize your term, validate whether or not the code that you have is correct, recommend a better fit if needed, and then enrich it with all of the other codes needed to truly describe this condition. That also comes along with that IMO ID that Andre talked about, giving you that future-proof protection of having the IMO lexical. Moving on to the next. Just going through more examples of how IMO is able to add back in information that could have been lost or never captured to begin with, and tying this to a use case like patient cohorting, for example. Let's say patients, these are 3 different descriptions of exactly the same thing, which is trying to say uncontrolled type 2 diabetes with renal manifestations. And these 3 cases, IMO was able to recognize that these all meant exactly the same thing. We were able to double check the code that did come along for the ride, validate that it was correct, and then add in the other associated codes. Why does this matter? If you're looking to put together a patient cohort that it encompasses all of your diabetic patients that have kidney problems, there may be a new treatment, a new medication that you want to do outreach about. You can't do that without that ICD-10 secondary code. That is where half of that information lives. And so while you may have curated and maintained a fabulous grouper to be able to pull these patients together, all 3 of these patients would have been missed in this example because they didn't have that secondary ICD-10 code. Precision normalize future-proofs your descriptions for whatever it is looking to be pulled into, for example, that secondary ICD-10 code. Going beyond the diagnosis space on the next slide, we can do the same thing for labs and medications. And you'll notice that we don't always need a code. In the lab example, we were getting labs in from 3 different systems that had different ways of documenting the same procedure, different code systems that came along with them. In some cases, no code. That is all right with Precision Normalize. We are able to recognize whether it's free text, whether it was captured within an EHR, IMO or not. Due to our large corpus of terminology, we have over 1.8 million diagnoses and even more procedures. We are able to recognize those terms and enrich it with the accurate codes. So all of your content, whether it is a problem, a procedure, a lab, or a medication, they will all be comprehensively and accurately mapped to the richness that is IMO's content. You'll see on the bottom of the slide is another example for medications where currently this customer did not have any RX norm codes present, and IMO Precision Normalize was able to enrich that. Moving on to the next. As Andre talked about, each week we're going to be diving into specific use cases and where Precision Normalize can plug in both inside and outside of the EHR to improve outcomes. One example here that we're going to dive into next week further is our clinical quality measure improvements. By unifying your data set and enriching it with missing codes, this will have downstream benefits for your measure achievement by pulling in the right patients. In this graphical representation of an actual client, we were able to normalize their data warehouse that they were using for their quality measure reporting. And when we normalized that data warehouse, in orange were the patients that were previously pulled into their measure, and the blue was the patients that were actually pulled into the measure after that code enrichment. And now we can have an accurate view of our clinical quality measure achievement and not only feel confident in what we are reporting, but also be able to make informed decisions of how to truly improve patient outcomes and deliver the highest quality of care possible. And Precision Normalize gives you the insights to be able to do that. And we will dive into further that use case further next week. Any questions?
Awesome. Thanks, Andre and Meg. So at this time, we'll be kicking off our Q&A session. If you have any questions from today's webinar or questions you have coming in, please enter them now, and our team will begin answering questions live. All right, so one came in, how does IMO assure data integrity across multiple data sources?
Sure, I can take that one. So team, where IMO can help with data integrity across multiple different data sources. One, it depends upon where that data is originating from. And two, are you aligning it on the same kind of patient or on the same kind of data set you're trying to look into? Good example, if you're trying to align claims data to clinical data, there will be a lot of gaps in the alignment of that information. However, if you're trying to align two different patients or even the same patient across those different data sets, IMO can look at each structured data point within that patient record, align that information to an IMO lexicon and an IMO description, and maintain that description over time as it evolves unique to that patient. The really key differentiator here is as you normalize and standardize and maintain patient populations across your ecosystem with IMO content, it becomes an insulating value to your organization to gain those kinds of ECQM value set insights that my colleague Meg was talking about earlier too. So as you think about the initial alignment, but also the maintenance of that information, IMO can help alleviate that burden and provide more trust back into your data through that workflow.
Awesome. Another question came in, what are common use cases for IMO Precision Normalize?
I could probably take that too. The key use cases that have come out using Normalize have actually been very, very verbose, as you guys can imagine. We like to call Normalize the Swiss Army knife of content standardization, normalization, and maintenance in the industry. So everything from enterprise data warehouse, cleanup and data quality insights, the ability to provide on-demand clinical decision support trigger methodologies upon ingestion and making sure that they're aligning correctly to the trigger supports themselves. Population health insights for self-service analytics across multiple different health systems, labs and lab alignment across your ecosystem, especially for ordering and resulting information for lab reporting, all the way to the use case of clinical research and trying to tee up data for synthetic control arms as you're trying to research externally for your partner organizations as well too. As you can imagine, clinical data and alignment of that clinical data, the claims data wholeheartedly has an impact on ACO and at-risk care modeling too. And one of the key points that we always like to exit with on any one of these kinds of webinars or any insights into IMO content is we're not upcoding, we're not changing the data, quite the opposite. IMO is helping recolorize that lost data, which wholeheartedly leads to better trustworthiness and maintenance in that information and alleviating the burdensome operation of the telephone game as it gets to organizations themselves.
Awesome. If data was complete during a POC documentation, why is normalization necessary?
I'm assuming POC in that case is probably point of care.
Point of care.
So if IMO is the terminology used for 90 to 95% of the US healthcare market in the point of care, we also understand where the skeletons are buried as that data is flowing downstream. Not a lot of our vendor partners adhere to the comprehensive representation of our content there, but also not all software solutions are also IMO licensed either. A lot of them only adhere to the minimum acceptance criteria of transmissions. So even though content might be comprehensively captured at the point of care, a lot of that data as it flows downstream, a lot of that data as it goes from one software organization to another software organization might only be able to accept a single code in that representation because that's what's regulatorily required for an organization to capture. And this is the problem that happens with the telephone game. So even though comprehensiveness might be captured at the point of care, it still might lose its fidelity as it flows downstream. And that gives any kind of aggregation or piping operation, ETL operation, an opportunity for helping in recolorization. And because IMO content is where that data started with at the point of care, we're the best kept secret in healthcare to help recolorize that data.
Thanks, Andre and Meg. All right, so it looks like that's all the questions that came in. So we're going to go ahead and close out for today. Hope you found everything useful. If you want more information about IMO solutions, please contact your IMO client executive, or you can email sales@imohealth.com. Thanks so much for attending, and please stay safe out there.
Thank you all.